The air is thick, heavy. It smells of boiled cabbage, carbolic soap, and something else, something metallic and vaguely sweet, the scent of despair. You can hear it too if you listen closely. A low, constant hum of human misery, punctuated by a sudden shriek from down the long, tiled hallway, a sound that echoes and then is swallowed by the silence that follows. The floor beneath your thin slippers is cold, so cold it seems to leach the warmth from your very bones. You pull the rough, grey wool blanket tighter around your shoulders, but it offers little comfort. It smells of dust and 100 other bodies that have huddled in it before you. Look around you. This is the day room. Dozens of women sit on hard wooden benches, or stand, or rock, or stare at a spot on the wall that only they can see. Some talk to themselves in frantic whispers. Others are perfectly still, their faces as blank and empty as porcelain dolls. There is no hope here, no cure. There is only waiting. Waiting for the next meal of watery stew. Waiting for the next order from a stern-faced nurse. Waiting for the next treatment. You've heard the stories, the ones whispered in the dark of the dormitory after the lights go out. Stories of the tubs filled with ice water, where you are held down until your skin turns blue and your teeth chatter so violently you fear they might break. Stories of being wrapped so tightly in wet, freezing sheets that you can't move, left for hours in a dark room, your mind screaming inside a silent, mummified prison. They say it's to calm you, to shock the madness out. But you've seen the eyes of the women who come back from these sessions. They are not calm, they are distant, hollowed out. A part of them left behind in the cold and the dark. And now there is a new rumor, something about a needle and a sleep so deep it borders on death. A coma cure, they call it. They say it can reset the mind, like winding a broken clock. But you've seen the violent shaking, the bodies convulsing on the beds. You've seen the fear, and you wonder, as you sit on this cold bench in this hopeless place, which is worse, the madness inside your own head, or the cures they offer to chase it away. This isn't a work of fiction. This was the reality for hundreds of thousands of people. A reality born of desperation, ignorance, and a profound misunderstanding of the human mind. Welcome to The Dark Historian. To understand the story of the lobotomy, you can't begin with a gleaming operating theatre or a confident surgeon. You can't start with the ice pick. No, to truly grasp why such a brutal procedure was not only conceived but celebrated, you have to start here. In the desperate, echoing halls of the lunatic asylum, you have to understand the world before it. A world without effective treatments, where mental illness was a life sentence to a living nightmare. By the turn of the 20th century, the landscape of mental health care in the Western world was dominated by a single, monolithic institution, the asylum. You've seen the pictures. Grand, Gothic structures of brick and stone, often set far away from cities, hidden behind iron gates and manicured lawns that belied the chaos within. They were built with good intentions, at least initially. They were a product of the Victorian era's belief in order and reform, a move away from the literal chains and dungeons of the old madhouses. The idea was something called moral treatment, a belief that with fresh air, meaningful work, and a calm, structured environment, the troubled mind could be gently coaxed back to sanity. For a time, in smaller, well-funded institutions, it sometimes even worked. But that time was short-lived. Here's the thing about good intentions: they are often crushed under the weight of reality. The reality was that industrialization and urbanization were creating immense social pressures. Populations boomed, cities swelled, and with them the number of people deemed insane or melancholic or hysterical or simply unable to cope skyrocketed. State after state, country after country, built more and bigger asylums, but they could never build them fast enough. These places, designed for a few hundred patients, soon held thousands. The ideal of moral treatment evaporated. There was no time for therapy, no resources for individual care. The asylum's primary function shifted from treatment to containment. They became human warehouses, vast, understaffed, and chronically underfunded dumping grounds for society's unwanted. The mentally ill, the elderly with dementia, alcoholics, epileptics, rebellious women, and anyone else who didn't fit neatly into the social order. Imagine being a doctor in one of these places in the 1920s or 30s. Every morning you walk into a ward with 200 patients and maybe 3 nurses to help you. The noise is constant. The smell is overwhelming. You see people lost in profound depression, unable to move or speak. You see others in the grips of mania, violent and unpredictable, a danger to themselves and everyone around them. You see patients with schizophrenia, haunted by voices and terrifying delusions, living in a reality you cannot begin to fathom, and you have nothing that truly works. You have sedatives like chloral hydrate or paraldehyde, which can knock a patient out but do nothing to cure the underlying illness. They are chemical straitjackets, nothing more. You feel a crushing sense of impotence. You are a physician, sworn to heal, but you are failing on an epic scale every single day. The desperation is a palpable thing, a poison in the air. This desperation, for both patient and doctor, is the fertile ground from which the terrifying cures of the pre-lobotomy era would grow. They weren't born of malice, not usually. They were born of a frantic, clawing need to do something. Anything. The first of these great, desperate hopes was hydrotherapy. It sounds almost pleasant, doesn't it? Like a spa treatment. The reality was anything but. Based on the old, misguided idea that mental illness was a disease of the nervous system that could be shocked back into alignment, hydrotherapy used water as a weapon. For an agitated or manic patient, the treatment might be the needle spray. You'd be stripped naked and forced into a stall where jets of ice-cold water would blast you from all sides with the force of a fire hose. It was a brutal, shocking assault on the senses, designed to overwhelm and exhaust you into submission. Or maybe you'd be prescribed the continuous bath. For this, you would be placed in a large tub of lukewarm water, sometimes for days at a time. A canvas sheet would be stretched over the top and clamped down, with a hole for your head, trapping you in the water. The theory was that it would be soothing. But can you imagine it? The endless boredom, the skin puckering and becoming raw, the claustrophobia, the humiliation of having to perform bodily functions right where you lay, submerged in your own filth, until a nurse decided to drain and refill the tub. But perhaps the most feared of all was the wet pack. The patient would be laid on a bed, and long linen sheets, just pulled from a bucket of ice water, would be wrapped around them. Tightly, each limb wrapped individually, then the torso, until they were completely immobilized, a human mummy bound in freezing, dripping cloth. They would be left like this for hours, sometimes overnight. The initial shock of the cold was agonizing, a searing, burning pain. Then came the violent shivering, and finally, after an hour or more, the body's own heat would slowly warm the sheets, creating a steamy, coffin-like environment. It was sensory deprivation and physical restraint combined. It was a living burial, and it was a standard medical procedure. Did it work? Not in any meaningful sense. It could exhaust a violent patient into temporary compliance. But it didn't touch the roots of their psychosis or depression. It was a tool of control, dressed up in the language of medicine. And yet, for doctors with no other options, it was something to write on a chart. It was an action, and in the face of overwhelming hopelessness, action feels better than nothing. But the desire for a true magic bullet was growing, something more medical, more scientific than cold water. The next great hope would come not from a bathhouse, but from a laboratory. It involved a needle, a hormone, and a terrifying descent into the body's most primal state of emergency. In 1927, a Viennese physician named Manfred Sakel was treating patients addicted to morphine. He was using insulin, the hormone that regulates blood sugar, in small doses to treat their withdrawal symptoms. One day, he accidentally administered an overdose to one of his patients. The man's blood sugar plummeted, and he fell into a deep coma, his body starting to convulse. Sakel panicked. He injected the man with glucose, and to his astonishment, the patient woke up. But something was different. The patient claimed that his craving for the drug was gone. His mind felt clear. A light bulb went off in Sakel's head. What if a controlled, reversible coma could somehow reboot a disordered brain? He theorized that the physiological shock of the coma, the starvation of brain cells from glucose, could disrupt the pathological pathways of psychosis. It was a wild, unproven leap of logic, but in the desperate world of 1930s psychiatry, it sounded like a miracle. He began experimenting on patients with schizophrenia. The procedure, which became known as insulin coma therapy, was terrifyingly complex and dangerous. Each morning, a group of patients would be injected with increasing doses of insulin. As their blood sugar dropped, they would begin to sweat profusely, to drool, to twitch. Then, one by one, they would slip into a deep coma. For about an hour, they would lie on their beds, suspended between life and death, often experiencing seizures. The nurses and doctors had to monitor them constantly, watching for the signs that the coma was becoming too deep, that the brain was beginning to suffer irreversible damage. At the critical moment, they would be brought back with an injection of glucose, often through a tube snaked down their nose and into their stomach. They would awaken groggy, confused, with no memory of the event. The risks were enormous. Some patients suffered violent, bone-breaking convulsions. Some aspirated on their own saliva and developed pneumonia. And some never woke up. The mortality rate was between 1% and 5%. Think about that. In the search for a cure, doctors were willing to employ a treatment that had a very real chance of killing the patient. And the results? For some, there seemed to be a dramatic improvement, especially in the early stages of illness. Patients who had been catatonic would start to speak. Those who were tormented by hallucinations would report moments of clarity. Sakel reported recovery rates as high as 88%. Asylums across Europe and America desperate for a breakthrough, rushed to build dedicated insulin coma wards. It was hailed as the first ever effective treatment for schizophrenia. But the magic didn't last. Over time, it became clear that many of the improvements were temporary. Patients would relapse, and subsequent studies with better controls showed that the success rates were far, far lower than what Sekel had claimed. The reboot was not a reboot at all. It was more like a temporary system crash. But for a time, it represented hope. A dangerous, frightening hope, but hope nonetheless. And it paved the way for an even more direct and more shocking method of inducing a seizure. While Sekel was putting patients into comas with insulin, two Italian neurologists, Ugo Saletti and Lucio Bini, were exploring a different path to the same destination, the convulsion. They were working from a simple and ultimately incorrect observation. They believed that epilepsy and schizophrenia were somehow antagonistic, that you rarely found a person who suffered from both. So, they reasoned, if you could artificially induce an epileptic seizure in a schizophrenic patient, maybe it would cancel out the psychosis. Their first challenge was how to induce that seizure safely and reliably. They started with chemical agents, but they were difficult to control. Then, Saletti had a grim inspiration during a visit to a Roman slaughterhouse. He saw pigs being stunned with electric shocks applied to their heads before being killed. They would fall to the ground unconscious and convulsing, but they weren't killed by the shock itself. Saletti wondered, could this be done to a human? In April 1938, they found their first human subject, a man who had been found wandering the streets of Rome, incoherent and delusional. In a terrifying and ethically questionable experiment, they strapped electrodes to the man's temples. The nurses and other doctors present were horrified, begging Saletti to stop. But he went ahead. He applied a small jolt of electricity. The man's muscles seized, and he cried out, "Not again. It's deadly." But he didn't have a full convulsion. Saletti and Bini increased the voltage and tried again. This time, the man's body went rigid, and he fell into a full-blown grand mal seizure, lasting for about a minute. When he woke up a short while later, he seemed calmer, more lucid. This was the birth of electroconvulsive therapy, or ECT. It was crude, brutal, and terrifying to witness. In these early days, patients were given no anesthetic, no muscle relaxants. They were fully conscious when the shock was delivered. The force of the convulsion was so violent that bone fractures, particularly of the spine, and broken teeth were common. The memory loss, both of the procedure and of the time around it, could be severe and permanent. And yet it spread like wildfire. Why? Because for one specific condition, severe depression, it actually worked. It was faster, cheaper, and safer than insulin coma therapy. For patients trapped in a suicidal, catatonic depression, a course of ECT could, and still can, be life-saving. But in the asylum, it was used for everything. Schizophrenia, mania, hysteria. It became another tool of control, another way to manage a chaotic and unmanageable population. So now, step back. Picture the landscape of psychiatry on the eve of the Second World War. The asylums are overflowing. The doctors are desperate. The available treatments are a collection of medieval-sounding tortures. Hydrotherapy, a practice of exhaustion and submission. Insulin coma therapy, a high-stakes gamble with a patient's life. And electroshock, a violent, bone-breaking jolt to the brain. This was the state of the art. This was the pinnacle of medical science for the mind. All of these therapies had one thing in common. They were attempts to cure the mind by brutalizing the body. They were based on the idea that a profound physiological shock could somehow reset a complex psychological disorder. They were born of desperation. And they were, for the most part, failures. The great mass of chronically ill patients in the back wards of the state hospitals remained untouched by these cures. They were still trapped. The world was crying out for something better, something decisive. A true cure, a surgical strike that could go directly into the brain itself and cut the madness out at its source. The stage was set. The audience was waiting for a miracle. What it got was a spike, and the story was just getting started. It didn't begin with a spike, not at first. The idea, in its infancy, was wrapped in the sterile cloth of medical science. It was conceived in a place of supposed enlightenment, spoken in hushed, academic tones in the lecture halls of Europe. It came from the mind of a man who was seen not as a monster, but as a savior, a pioneer. To understand how a medical procedure could become an act of barbarism, you can't start in a blood-spattered asylum. You have to go somewhere else. You have to go to Lisbon in the 1930s, and you have to meet the man who lit the fuse. His name was Antonio Egas Moniz. Picture him, a man of immense stature in Portuguese society. He wasn't just a neurologist. He was a statesman, a diplomat, a professor. He carried himself with an air of unshakable confidence, the kind that comes from a lifetime of success and public adoration. He had already developed a groundbreaking technique called cerebral angiography, a way to visualize the brain's blood vessels, which had nearly won him a Nobel Prize before. Nearly. For a man like Moniz, a man driven by a towering intellect and an equally towering ego, nearly is a powerful motivator. He was a man searching for his masterpiece, his legacy. He looked at the human mind, at the landscape of mental illness, and saw the last unconquered frontier of medicine. In the crowded, desperate asylums of the world, he didn't just see suffering. He saw an opportunity to make a mark on history that no one could ever erase. The problem, as he saw it, was the brain's wiring, specifically the frontal lobes. This part of the brain, right behind your forehead, was thought to be the seat of complex thought, of emotion, of the very self. Moniz developed a theory. He believed that in patients with conditions like anxiety, depression, or psychosis, certain neural pathways had become pathologically fixed. The brain was stuck in a loop, replaying the same destructive thoughts, the same paralyzing fears over and over. What if, he wondered, you could just cut those connections? What if you could surgically sever the faulty circuits? If you could physically disconnect the obsessive thoughts from the emotions they produced, could you silence the storm? It was a radical idea, a frightening idea. It was also, at the time, completely untestable. There was no way to know which circuits were the problem, or what cutting them would truly do. It was like trying to fix a radio by smashing it with a hammer, hoping you hit only the broken parts. But Moniz was a man of action. He needed a proof of concept, and in 1935, at a medical conference in London, he found one. Imagine you're in that auditorium. The air is warm, thick, with the smell of old paper and pipe smoke. On the stage, two American scientists, Carlisle Jacobson and John Fulton, are presenting their research. They're talking about two chimpanzees. Their names were Becky and Lucy. Becky, they explained, had a problem. She was prone to fits of rage. When she failed a task or was denied a treat, she would fly into a violent tantrum, throwing herself against the bars of her cage. She was, in the detached language of the scientists, a difficult subject. So they performed an operation. They surgically removed the frontal lobes of Becky's brain, and after she recovered, the change was profound. The tantrums stopped completely. If Becky failed a task now, she just shrugged it off and moved on. The frustration, the rage, the anxiety, it was all gone. She was placid, docile, cured, or so it seemed. You can almost feel the moment in that London hall. For most in the audience, it was a curious bit of animal research. But for Egas Moniz, it was something else entirely. It was a lightning strike. A revelation. As one attendee later recalled, Moniz stood up and asked a fateful question: if frontal lobe damage could pacify a chimpanzee, could a similar, more targeted lesion be used to treat mental illness in humans? The room was silent. From a frustrated chimpanzee to a suffering human being. Is that a leap of logic? Or is it a leap of reckless, unbridled ambition? For Moniz, it was the key. He had his proof of concept. He returned to Lisbon, his mind racing. He had the theory. He had the animal model. Now, he just needed a human subject. He didn't have to wait long. He found a willing collaborator in the neurosurgeon Almeida Lima. They found their first patient in the Santa Marta Hospital in Lisbon. She was a 63-year-old woman, institutionalized for severe depression, anxiety, and paranoia. She was, in the eyes of the hospital, a hopeless case, the perfect candidate for a procedure that had never been tried before. On November 12, 1935, they took her to the operating theater. This was not the brutal, swift act of an ice pick. This was surgery. It was methodical. It was precise. And it was terrifying. The patient was awake the entire time, her head shaved and sterilized. Moniz and Lima drilled 2 small holes into her skull, one on each side of her forehead, in the upper part of her temples. You can imagine the sound. The high-pitched whir of the drill, the low grinding as it passed through the bone into the sacred space of the mind. Through these holes, they inserted a narrow cannula, and then they injected pure, absolute alcohol directly into the white matter of her prefrontal cortex. The goal was to create a neat, spherical lesion, chemically destroying the brain tissue and severing the connections Moniz believed were causing her distress. They waited, they watched, and then they repeated the procedure on another patient, and another. Over the next few weeks, they operated on the first 7 patients. Moniz, however, was not satisfied with the alcohol. It was imprecise. The lesions were not as controlled as he wanted. He needed a better tool. So he invented one. He called it the lobotomy. It was a slender rod with a retractable wire loop at the end. Once inserted into the brain through the drilled holes, the surgeon could push a plunger, deploying the wire loop. Then they would rotate the lobotomy, and the wire would spin like a tiny, sharp egg beater, coring out a small piece of the frontal lobe. Think about that for a moment. A custom-designed instrument made for the express purpose of blindly cutting and removing pieces of a living human brain. Moniz and Lima performed the procedure on their next 13 patients using this new device. 20 patients in total, and then Moniz published his findings. The results, he claimed, were a stunning success. Of the 20 patients, he declared 7 cured, another 7 improved, and only 6 unchanged. The patients were calmer. Their anxieties, he wrote, had vanished. He focused on the reduction of symptoms. The paranoid woman was no longer paranoid. The agitated man was now calm. To a world with no other options, no effective treatments for severe mental illness, this sounded like a miracle. The news spread like wildfire through the international medical community. Here, at last, was a solution. A real, physical intervention for the ethereal torments of the mind. It was hailed as a breakthrough, a bold new frontier in psychiatric medicine. But what was really happening to these patients? What was being lost in exchange for this newfound calm? The reports from other doctors, the ones who weren't so invested in the procedure's success, told a different story. They noted other changes. A loss of inhibition, apathy, a profound lack of judgment and foresight, a blunting of emotion. The patients were calmer, yes, but it was the calmness of a quiet, empty room. The storm was gone, but in many cases, so was the weather. The person who existed before the operation was often gone, replaced by a placid, childlike shell. One of Moniz's own colleagues, his junior partner, noted with alarm that all the patients, even the cured ones, seemed diminished after the operation. He observed that it is possible that the effective indifference and the lack of initiative may be the price that has to be paid for the symptomatic improvement. The price. Was it a price worth paying? For desperate families, for overwhelmed asylum doctors, the answer was often yes. A quiet, manageable relative was better than a violent, suffering one. The procedure, which Moniz called a lobotomy, began to be adopted around the world, and Egas Moniz became a global celebrity, a medical hero. He was nominated for the Nobel Prize in 1937, then again in 1938. The war interrupted the proceedings, but the nominations kept coming. His work was seen as the first great hope for the incurably insane. And then, in 1949, it happened. 13 years after he drilled the first holes into a patient's skull. Inspired by a single agitated chimpanzee, Antonio Egas Moniz was awarded the Nobel Prize in Physiology or Medicine for his discovery of the therapeutic value of lobotomy in certain psychoses. Let that sink in for a moment. The highest, most prestigious honor in all of science, an award given to the likes of Marie Curie and Albert Einstein. It was now given for a procedure that involved blindly destroying parts of the brain with a wire loop. The Nobel Committee's decision cemented the lobotomy's place in the medical mainstream. It wasn't just an experimental procedure anymore. It had the ultimate seal of approval. How could it be wrong if it had won a Nobel Prize? This single act gave license to doctors around the world to adopt and modify the procedure, to push it further and further. The controversy was immediate, and it has never gone away. Even at the time, many in the scientific community were horrified. They argued the procedure was based on flimsy evidence, that the side effects were catastrophic, and that the cures were nothing more than the creation of manageable invalids. But the prize was given, and the Nobel Foundation has, to this day, refused all calls to rescind it. They stand by the decision, arguing that it must be viewed in the context of its time. A time of desperation, a time before any effective psychiatric drugs. Moniz himself would not perform the procedure for long. In 1939, a patient from a mental hospital, who believed the doctor had ruined his mind, shot Moniz multiple times. He survived, but was left partially paralyzed, and his surgical career was over. He had opened Pandora's box, but he would not be the one to see what fully emerged. He had given a terrible idea the stamp of legitimacy. He had turned a theory into a tool. He had received the world's highest honor for it. But the story of the lobotomy was only just beginning. Moniz had created a surgical procedure, one that required a hospital, a trained neurosurgeon, and an operating theater. It was slow. It was expensive. Across the Atlantic, an American doctor was watching. A man with the same ambition as Moniz, but with an added flair for showmanship and a terrifying lack of restraint. He saw Moniz's lobotomy and thought it was a good start. But it wasn't enough. It wasn't efficient. He believed he could do it better, faster, cheaper. He believed he could turn it from a niche surgery into a mass-produced cure, and he wouldn't need a drill or a leucotome or an operating room. All he would need was a hammer and a tool that you could find in any kitchen icebox. But a tool from an icebox is not a medical instrument. It is a crude, simple thing, meant for breaking apart frozen blocks, not for navigating the most complex and delicate structure in the known universe. To even conceive of such a leapter, see an ice pick, and imagine it as a key to unlock the mind requires a very specific kind of person. A person with immense confidence, unshakable conviction, and a terrifying lack of doubt. That person was an American doctor named Walter Jackson Freeman II. And if you want to understand how the lobotomy went from a rare, experimental surgery in Europe to a full-blown medical craze in the United States, you have to understand him. He wasn't just a practitioner of the lobotomy. He was its prophet, its greatest salesman. Walter Freeman was not what you might picture. He wasn't a shadowy figure lurking in a Gothic hospital. Far from it. He was charismatic, impeccably dressed, a man of formidable intellect and even more formidable ambition. Born into a line of distinguished physicians, he felt the immense pressure of his own legacy before he had even made it. His grandfather had been a famous surgeon, his father a respected pathologist. Walter Freeman was determined not to just join their ranks, but to eclipse them entirely. He was a neurologist by training, not a surgeon, and this is a critical detail. He studied the brain, its diseases, its intricate pathways. He ran the neurology departments at George Washington University. He saw, every single day, the absolute devastation wrought by severe mental illness. He walked the wards of the great, sprawling asylums. You have to picture these places. In the 1930s and 40s, they were often called insane asylums without a hint of irony. They were human warehouses, vast, underfunded, overcrowded buildings filled with the desperate and the forgotten. Schizophrenia, severe depression, bipolar disorder, obsessive-compulsive disorders conditions we now have treatments for were then life sentences. Patients were often restrained for days, left in squalor, subjected to brutal and ineffective treatments like insulin coma therapy or electroshock. Families were torn apart, their savings drained, with no hope of recovery. The air in these places was thick with despair. Walter Freeman saw himself as a crusader, marching into this darkness. He was a man with a hammer and to him, the entire world of mental illness looked like a nail. When he read of Egas Moniz's work in Portugal, it was like a bolt of lightning. Here, finally, was not just a treatment, but a potential cure, an active, physical intervention. Something you could do. It appealed to his nature as a man of action. He saw the lobotomy not as a crude severing of brain tissue, but as a precise surgical strike against the very circuits of psychosis. He believed that the frontal lobes, the seat of complex emotion and self-awareness, could become pathologically overactive. He imagined the neural pathways caught in an endless, agonizing loop of worry, fear, and delusion. Moniz's procedure, he thought, was the answer. It was a way to cut the feedback loop. But Freeman was a neurologist. He couldn't perform the surgery himself. He needed a partner, a pair of hands. He found them in a young, talented, and ambitious neurosurgeon named James Watts. Watts was everything Freeman was not: cautious, meticulous, a classically trained surgeon who revered the sanctity of the operating room. Together, they were a study in contrasts: the visionary and the technician, the showman and the craftsman. In 1936, just months after Moniz's first procedures, Freeman and Watts performed their first lobotomy in the United States. Their patient was a 63-year-old woman from Kansas named Alice Hood Hammart. She suffered from agitated depression and anxiety, so severe she had contemplated suicide. Freeman, with his persuasive charm, convinced her husband that this new, experimental procedure was her only hope. The operation they developed was a refinement of Moniz's original method. It became known as the Freeman-Watts procedure, or the standard lobotomy. It was still a brutal affair. Imagine the scene: the stark white of the operating theatre. The patient under anesthesia. Watts would drill 2 small holes, one on each side of the head, through the skull in the temple region. These were called burr holes. They were just wide enough to admit a specially designed instrument. This instrument was called a leucotome. It was a long, thin cannula, like a thick needle, with a retractable wire loop at its tip. Once the leucotome was inserted through the burr hole and into the frontal lobe of the brain, Watts would extend the wire loop and rotate the instrument. A sweeping, cutting motion. The goal was to sever the connections, the white matter fibers, that linked the frontal lobes to the thalamus, a deeper part of the brain that acts as a relay station for emotional information. Think of it like this. Imagine a city's telephone exchange, where all the emotional calls of anxiety and panic are being routed through one central hub, creating a storm of noise. Freeman and Watts believed they could go into that exchange and just cut the cables. They performed 6 cuts in Alice Hammart's brain, 3 on each side, a series of precise, blind sweeps through the most sensitive tissue in the human body. And at first, it seemed like a miracle. Alice Hammart survived. Her crippling anxiety was gone. She was calm, placid, even. Freeman declared the operation a resounding success. He was euphoric. He and Watts published their findings, trumpeting the procedure as a revolutionary breakthrough. And the desperate were listening. Families with loved ones lost to the fog of mental illness began flocking to them. They were seen as pioneers, miracle workers. Freeman and Watts performed more and more of the procedures. They refined their technique, creating precise measurements and angles for the insertion of the leucotome, trying to bring a scientific rigor to the act of blindly cutting through the brain. They called their target area the golden section of the frontal lobe, as if they were artists revealing a perfect form, rather than surgeons severing a living mind. But Walter Freeman was not content with this. The standard lobotomy, the Freeman-Watts procedure, was still major surgery. It required a trained neurosurgeon like Watts, a fully equipped operating room, general anesthesia, and a lengthy hospital stay. It was expensive, it was slow, and for a man like Walter Freeman, a man who saw a world drowning in madness, the operating room was a bottleneck. There were hundreds of thousands of patients languishing in state asylums. He couldn't possibly save them all one by one on an operating table. It was too inefficient. He dreamed bigger. He wanted to take his cure to the masses. He needed a method that was fast, cheap, and simple, something that could be done in a doctor's office, or even in the asylum wards themselves. He became obsessed with the anatomy of the skull. He would spend hours in the lab, studying skeletons, looking for a shortcut, a back door to the frontal lobes. The thick bone of the temples required a drill, and a drill required a surgeon. But he found another way in, a place where the bone was shockingly thin, paper thin. You can feel it on yourself. Just above your eyeball, beneath the eyebrow, there is a small patch of bone there called the orbital plate. It is the roof of the eye socket and the floor of the skull, and it is incredibly fragile. Freeman realized that you could pass a sharp instrument through that thin plate of bone directly into the frontal lobes without ever needing to drill through the skull. It was a terrifying, audacious idea to approach the brain through the eye socket. And this is where the story turns, where the partnership between the charismatic visionary and the cautious surgeon begins to fray. James Watts was horrified by this concept. To him, it was a barbaric leap backward. It abandoned all pretense of surgical precision. It was reckless, dangerous, and unprofessional. He wanted nothing to do with it. But Walter Freeman was not a man to be deterred by caution. He was a man possessed by a vision. He saw a streamlined future. No operating room, no neurosurgeon, no expensive equipment. All he needed was a way to knock the patient out briefly. And for that, a simple electroshock machine would do. And he needed an instrument. Something sharp enough and strong enough to pierce the orbital plate without breaking. Something long and thin that he could grip firmly. He found it in his own kitchen drawer. An ice pick. It was the perfect tool. Simple, readily available, effective. He practiced first on a grapefruit, then on cadavers at the local morgue. He would take the ice pick, place its point in the corner of the eye socket, just under the eyelid. Then he would take a small hammer, a surgical mallet, and tap. A sharp, quick tap. The pick would break through the thin orbital bone with a sickening little crack, sliding directly into the prefrontal cortex. Once inside, he would move the pick back and forth. A swishing, sweeping motion, like a windshield wiper, scrambling the connections, destroying the delicate fibers that governed personality, emotion, and foresight. Then he would pull it out and do the same on the other side. The entire procedure took less than 10 minutes. He called it the transorbital lobotomy. The world would come to know it by a simpler, more chilling name: the ice pick lobotomy. Freeman was immensely proud of his invention. He saw it as a triumph of American ingenuity. He had taken a complex, difficult European surgery and streamlined it. He had made it efficient. He had democratized it. He was no longer just a doctor. He was an innovator. In 1946, he performed his first transorbital lobotomy on a living patient without his partner, James Watts, even being present. His subject was a housewife named Sally Ellen Ionesco, institutionalized for her severe depression and suicidal thoughts. Freeman rendered her unconscious with an electroshock machine, pulled back her eyelid, inserted the ice pick, tapped it through the orbital plate, and severed her frontal lobes. When she woke up, she was docile. She was no longer suicidal. Freeman, once again, declared it a spectacular success. He had done it. He had found his method. He had his tool. He had his technique. And he had a nation full of asylums waiting for a cure. James Watts was appalled. This was not medicine in his view. This was butchery. It was a brutal, blind, and reckless assault on the human brain. The two men, once partners in a medical revolution, were now on a collision course. Their partnership, which had brought the lobotomy to America, would soon shatter, leaving Freeman alone, untethered, and free to begin his crusade in earnest. And the story was just getting started. Freeman now saw a path forward, a way to bring his salvation to every dark corner of every forgotten ward in the country. He wasn't just going to perform the ice-pick lobotomy. He was going to sell it to the world. And to do that, he would need to become more than a doctor. He would need to become a performer, a traveling evangelist for his new 10-minute miracle cure. He just needed a stage, and he found the perfect one. A custom-fitted van that he would soon call his lobotomobile. With his custom van, Walter Freeman was no longer bound to the sterile confines of a hospital. He was a missionary, and the open road was his new cathedral. You can almost picture it. A heavy, unassuming vehicle rolling down a dusty American highway in the late 1940s. Inside, a man with a singular, radical vision and a small leather case containing his new tools. He was bringing his cure to the people, whether they were in a grand state hospital or a small-town doctor's office. But to understand what was in that case, to understand the leap he was about to make, you have to understand the problem he was trying to solve. The original lobotomy, the prefrontal leucotomy, was a messy affair. It was major surgery. It meant drilling holes in a person's skull. It required a skilled neurosurgeon, an anesthesiologist, a fully equipped operating room, and a lengthy, expensive hospital stay for recovery. It was a bottleneck. For a man like Freeman, who saw tens of thousands of desperate souls locked away in asylums, this was far too slow. It was inefficient. He believed he had the cure for a national crisis, but he couldn't scale it up. And there was another, more personal problem. Walter Freeman was not a surgeon. He was a neurologist. His expertise was the brain's wiring, not the skull's plumbing. He could diagnose and theorize, but he always needed a surgeon like James Watts to do the actual cutting. This dependence must have grated on him. He was the visionary, the architect of the procedure, yet he was reliant on another man's hands to carry it out. He needed a way to bypass the skull, bypass the operating room, and bypass the surgeons themselves. He needed a shortcut, a back door into the human mind, and he found one. The idea didn't spring from his mind fully formed. It began, as many scientific advancements do, by reading the work of others. He learned of an Italian psychiatrist, Amaro Fiamberti, who had been experimenting with a similar problem in the 1930s. Fiambity wasn't cutting brain fibers. He was trying to inject chemicals, like alcohol, directly into the frontal lobes to induce therapeutic shock. And to do that, he had found a route that didn't require drilling through the thickest parts of the skull. He went through the eye socket, the bone at the back of the orbit. The thin layer that separates the eye from the brain is surprisingly delicate. In some places, it's as thin as a fingernail. Fiambity had proven you could puncture it with a long, sharp needle. When Freeman read this, a terrible and brilliant idea began to form. Why inject chemicals? Why not just use the needle itself to do the cutting? It was brutally simple. It was elegant in its barbarism. The legend, the one that has been told and retold, is that Freeman, mulling this over, went into his own kitchen. He opened a drawer and his eyes fell upon a common household tool, an ice pick. It was long, slender, and sharp, strong enough to be hammered, delicate enough to be precise. He took it into his hands, feeling its weight. This, he thought, could be the key. The key to unlocking the mind, and the key to unlocking his own ambition. He first experimented on grapefruits, then on cadavers, practicing the technique. He needed to find the perfect angle, the right amount of force. He developed a more specialized instrument, which he called the orbitoclast. It was essentially a refined ice pick made of surgical steel, with a sharper point and markings along the shaft to measure depth. But the name that stuck, the one that history remembers, was the one from his kitchen, the ice pick lobotomy. The name itself sends a shiver down the spine. It strips away all medical pretense. It's raw, violent, and terrifyingly domestic. The procedure he developed was a marvel of grim efficiency. It was a performance, a ritual he would perfect over thousands of repetitions. Imagine the scene. A patient, often agitated or deeply withdrawn, is brought into a room. It might not be an operating theater. It could be a small treatment room in an asylum, or even a hotel room Freeman had rented for the day. There is no general anesthetic. That would take too long and require a specialist. Instead, the patient is rendered unconscious in a much faster, cruder way, electroconvulsive therapy. 2 electrodes are placed on their temples. A switch is flipped. The body convulses violently as the electric current seizes the brain. Then, stillness. A temporary, forced coma. Now, Freeman works fast. He has only minutes before the patient begins to stir. He lifts the patient's upper eyelid. He takes the orbitoclast, his steel ice pick, and places the tip into the corner of the eye socket, just above the eyeball, pointed slightly towards the nose. He slides it in, up along the bone, until it stops against that thin shelf of bone at the back of the socket. And then comes the sound. A sickening, muffled tap. He takes a small surgical mallet, often made of bronze, and strikes the end of the orbitoclast. Tap. Tap. The instrument breaks through the orbital plate with a slight crack, a sound that only he and his assistants can hear. It is now inside the cranial cavity. It is inside the patient's brain. He pushes it in about 2 inches to the pre-marked line. Now the real work begins. With the instrument buried deep in the frontal lobe, he moves it. He sweeps it back and forth, like a windshield wiper in a controlled arc. He is not looking at what he is cutting. He is doing this by feel, by instinct, by a mental map of the brain that he holds in his head. He is severing the delicate thalamocortical fibers, the very connections that are thought to generate complex emotion, foresight, and the self. He makes one deep sweep, then another, shallower one. Then he pulls the instrument out. But he's not done. He moves to the other eye, and he does it all again. Lifts the eyelid, inserts the pick, tap, tap. The bone gives way. He pushes it in. He sweeps it left and right. Swish, swish. He withdraws the tool. The entire procedure, from the first jolt of electricity to the final pull of the orbitoclast, can take less than 10 minutes. Before we follow the path of this terrible new efficiency, this assembly line of the mind, if you find these dark histories a way to quiet your own thoughts at night, please consider subscribing to The Dark Historian. Every subscription helps us continue to unearth these forgotten stories. Now, back to the quiet room and the dawning of a new era. When the patient wakes up, they are often disoriented, nauseous. They almost always have two spectacular black eyes, caused by the trauma and bleeding inside the eye socket. Sometimes they are calm. Sometimes they are confused. But something is invariably different. The frantic energy, the deep depression, the violent outbursts, they are often gone, replaced by a placid, childlike state, a blankness. For Walter Freeman, this was success. He had done it. He had created a lobotomy that was fast, cheap, and required no surgeon. He called it the transorbital lobotomy. It was his masterpiece. He could now perform dozens of these in a single day. He was no longer tethered to James Watts or the slow, methodical world of the surgical suite. He could take his show on the road. The partnership with Watts, his surgical collaborator for a decade, crumbled. Watts was a surgeon. He was horrified by this new, blind procedure. He saw it as a reckless and brutal mutilation. To go hammering a sharp object into a person's brain through their eye socket, without even being able to see what you were doing, was an unforgivable violation of his medical ethics. It was a betrayal of the Hippocratic Oath. He pleaded with Freeman to stop, but Freeman saw Watts as a relic, a man clinging to outdated, overly cautious methods while millions suffered. The two men, once pioneers together, had an explosive falling out. Their partnership was dissolved. Watts would continue to perform the original surgical lobotomy, but his practice was soon dwarfed by Freeman's whirlwind of activity. Freeman was unleashed. He began to travel the country in his van, a vehicle that soon earned the grim nickname, the Lobotomobile. He would arrive at state hospitals that were overflowing with patients, institutions that were more like warehouses for the mentally ill than places of healing. The staff were overwhelmed, desperate for any solution, and Freeman arrived like a savior. He would set up his small kit in a side room, and the patients would be brought to him, one after another. He was a showman. He was known to be ambidextrous, and sometimes, for the sake of speed and dramatic flair, he would insert an orbitoclast into each eye socket at the same time, hammering them in one after the other, and then sweeping them simultaneously. A bilateral lobotomy in a single, horrifying flourish. The nurses and doctors who watched were often a mixture of awe-struck and nauseated. They were witnessing something that felt both like a medical miracle and a profane violation. This wasn't just surgery anymore. It was a crusade. Freeman wasn't just treating patients. He was trying to change the world, one severed nerve fiber at a time. He believed, with every fiber of his being, that he was a liberator. He was emptying the asylums. He was returning husbands to their wives, daughters to their mothers, He saw the black eyes and the vacant stares not as signs of damage, but as the unavoidable side effects of a cure. The quiet, passive person who emerged from the procedure was, in his eyes, a success story. They were no longer a burden on their family or the state. They were manageable. The ice pick had revolutionized the lobotomy. It had transformed a rare and dangerous brain surgery into a quick, outpatient procedure. It took the practice out of the hands of the elite neurosurgeons and put it into the hands of a single, determined neurologist with a mallet and a messianic complex. The floodgates were now open, and what followed was a torrent of altered minds and broken lives spreading across the country from the back of a van. The quiet hum of its engine on the highway was the sound of a new and terrible chapter in medical history just beginning. And the story was about to get much, much louder. The sound of that engine wasn't just loud, it was the sound of a promise. Or at least, that's how it was sold. Picture a station wagon, or maybe a large sedan, something unassuming, rolling down a dusty American highway in the late 1940s. It wasn't just a car. It was a clinic on wheels, a mobile operating theater for the mind. Walter Freeman called it his lobotomobile, and inside he carried his simple, terrible tools, the orbitoclast, the mallet, and a conviction so absolute it bordered on the divine. When the lobotomobile pulled into town, it was an event. It wasn't a quiet medical consultation. It was a spectacle. Freeman was a showman, a missionary for his own invention. He would arrive at state hospitals, places often hidden away from public view, places filled with the forgotten and the desperate. And he would throw open the doors. He invited the press. He invited medical students. He invited anyone who would watch. He wanted an audience, because what he was doing, he believed, was a revolution. Imagine the scene, a crowded lecture hall or an operating theater in some underfunded state asylum. The air is thick with the smell of antiseptic and something older, a scent of institutional despair. The light is harsh. On a gurney lies a patient, sometimes heavily sedated, sometimes just held down. And at the center of it all is Freeman. He's not the image of a cautious, meticulous surgeon. He's a performer. He's energetic, charismatic, almost joyous in his work. He moves with a swift, practiced confidence that is both mesmerizing and deeply unsettling. He would explain the procedure with the flair of a magician revealing a trick. No need for a sterile operating room, he'd proclaim. No need for complex drilling through the thickest part of the skull. This was a doctor's office procedure. Simple, elegant. He would take the orbitoclast, that refined ice pick, and hold it up for the crowd to see. He would place its tip just under the patient's eyelid, in the corner of the eye socket. Then he would take the small mallet. Tap, tap. The sound is small, but in the tense silence of the room, it's like a gunshot. A sickening little crack as the thin bone of the eye socket gives way. The instrument is now inside the skull, inside the frontal lobe of the brain. And then the part that made even seasoned observers flinch. Freeman would sweep the instrument back and forth, a brisk, almost casual movement. Like a windshield wiper, as one observer chillingly described it. Severing the connections, scrambling the delicate pathways that held a person's thoughts, their fears, their very soul. And, get this, sometimes, to add a little flourish to his performance, he would do two at once. An orbitoclast in each hand, driven into each eye socket, one after the other. He would then sweep them both in unison. A moment of grotesque symmetry. The entire thing, from start to finish, could take less than 10 minutes. Then, a bandage over the eyes, and the patient would be wheeled out. Next, he would say. This was the assembly line. In a single day, Freeman might perform 20, sometimes 25 lobotomies. He moved from one patient to the next with a terrifying efficiency. There was no time for careful consideration of individual cases, no deep dive into their psychiatric history beyond a quick glance at a chart. They were simply names on a list, problems to be solved with a tap and a swish. The sheer speed of it defied all medical convention. He often didn't even wear surgical gloves. He saw sterilization as a time-consuming formality that got in the way of his crusade. Who were these people on the gurneys? They were the silent, forgotten populations of mid-century America. In the crowded, understaffed state asylums, they were the problem patients. The ones who were violent or catatonic or simply too difficult for the overworked staff to manage. For the hospital administrators, Freeman's visit was a godsend. The lobotomy was pitched as a management tool. It didn't necessarily cure anyone, but it often made them docile, quiet, blank. It turned a difficult patient into a compliant one, freeing up beds and reducing the burden on the staff. It was a solution born of desperation and institutional convenience. But his targets weren't only in the asylums. His message of a quick fix for mental anguish resonated far beyond the hospital walls. And this is where the story gets even more insidious. Freeman began to market his procedure to a new kind of patient, the American housewife. Think about the post-war era, the 1950s. A time of rigid social expectations. Women who had worked in factories during the war were now pushed back into the home. They were expected to be perfect mothers, perfect wives, to find ultimate fulfillment in domestic life. But for many, this idyllic picture was a prison. They suffered from what was then vaguely termed neurosis, or anxiety, or melancholia. Today, we would call it depression, postpartum depression, or crippling anxiety from social isolation. But back then, these were often seen as female hysterics, as a failure to properly adjust to their role. These women weren't insane in the way the asylum patients were. They were functioning, but they were unhappy. They were anxious. They were overwhelmed. And Walter Freeman offered their husbands, and sometimes the women themselves, an almost irresistible promise. A simple 10-minute procedure that could smooth out the rough edges of a personality. It could calm the nerves, end the weeping, and restore tranquility to the home. He was selling peace of mind, delivered with a mallet. He performed lobotomies in his own office in Washington, D.C. A woman could come in for a consultation and, a short while later, walk out or be led out, fundamentally changed. One of his most famous patients was the sister of a future president, Rosemary Kennedy. But for every famous name, there were thousands of anonymous women whose families made a desperate choice. They were mothers who were perhaps too emotional, wives who were too argumentative, women who simply didn't fit the mold. The lobotomy became a tool of social control, a way to enforce conformity, disguised as a medical cure. The media, for a time, was completely captivated. Newspapers and magazines ran glowing articles about this miracle procedure. Freeman was a celebrity doctor, a pioneer who was bravely venturing into the final frontier of the mind. He was lauded for bringing hope to the hopeless. The sheer theatricality of his demonstrations made for great copy. The story of the ice-pick lobotomy was shocking, modern, and compelling. Few journalists at the time seemed to ask the hard questions. They didn't focus on the outcomes, on the people left emotionally blunted, apathetic, and childlike. They didn't report on the relapses or the deaths, which occurred in a significant number of cases. They reported the promise, not the reality. It is a difficult thing to picture, this procession of souls lining up for a procedure that would irrevocably alter them. Before we continue to follow Freeman on his cross-country journey, if you find these deeper histories valuable for your quiet hours, consider subscribing to The Dark Historian. Your support helps us to keep telling these important, forgotten stories. Now, back to the asylum, where the lobotomobile has just pulled up to another desperate institution. The staff at these hospitals would often prepare for his arrival for days. They would select the patients they deemed most suitable. This selection process itself is a dark story. It was rarely about who might benefit the most. It was about who was the most trouble. The patients themselves had no say. They were wards of the state, with their rights stripped away the moment they entered the institution. They were brought to a room, often without any explanation of what was about to happen to them. They only saw a confident man with a sharp instrument and a hammer. Imagine the fear, the confusion. For those who were lucid enough to understand, it must have been a unique kind of terror to know that a man was about to intentionally and violently damage your brain, the very core of who you are, and to be utterly powerless to stop him. There are accounts from nurses and attendants who were haunted for the rest of their lives by the things they saw on the days. Dr. Freeman came to visit. They spoke of the mechanical, impersonal nature of it all, the way patients were treated not as people, but as objects on a conveyor belt of treatment. The aftermath was often a ward of ghosts, people who looked the same but were hollowed out. The spark was gone. The severe anxiety might be gone, yes, but so was joy, so was ambition, so was creativity. They were left in a state of perpetual childhood, a placid emptiness that was mistaken for a cure. They were easier to manage, and in the cold calculus of the asylum, that was a victory. Freeman kept meticulous records, often taking photos of his patients before and after. He would present these as proof of his success. A before photo might show a person in distress, their face etched with anguish. The after photo would show someone with a placid, vacant smile. To him, that vacant smile was the picture of health. He traveled over 100,000 miles in his lobotomobile, leaving a trail of these altered minds in his wake. He kept a map marking every town where he had performed his work. He was a man possessed by his own creation, blind to its devastating consequences. He saw every criticism as an attack from a medical establishment that was too timid, too stuck in the old ways. He believed he was a liberator, freeing people from the prison of mental illness. He never seemed to grasp, or perhaps refused to grasp, that he was often just building a different kind of prison, a quieter, emptier one, right inside their own skulls. This era, the age of the lobotomobile, represents the absolute peak of the procedure's acceptance and Freeman's influence. It was a perfect storm of a desperate public, an overburdened mental health system, an uncritical media, and one man's unshakable, terrifying self-belief. He wasn't just a doctor, he was a salesman, and he was selling a product that many people were desperate to buy. The idea that you could simply cut away the bad parts of a person, like removing a tumor, was powerfully seductive. But the science was a sham. The frontal lobes are not the seat of mental illness. They are the seat of judgment, of personality, of executive function. What Freeman was doing was not a precision strike against a disease. It was a brutal, clumsy assault on the very essence of human identity. He was changing people, not curing them. And for a long, dark decade, America watched and, for the most part, applauded. The quiet hum of the lobotomobile's engine on the highway was carrying this new gospel of the mind across the nation. But as the miles racked up and the number of patients climbed into the thousands, a different kind of noise was beginning to build. It was quieter at first. The whispers of concerned colleagues, the troubling reports from families who found their loved one was not cured, but gone. A new medication was being developed in Europe, one that could calm patients without destroying their brains. The world was on the cusp of a pharmaceutical revolution. And, for Walter Freeman and his ice pick, the road ahead was about to get very, very rough. The applause was starting to fade, and a murmur of doubt was beginning to take its place. That murmur of doubt, it didn't start in a medical journal or a university lecture hall. It started in quiet living rooms, in the sterile corridors of asylums, in the strained, hushed conversations between a husband and a wife. It began with a look in the eyes of someone you loved, someone you had sent away to be fixed, only to have them returned to you different, vacant. This is where the story of the lobotomy always ends up. Not in the gleaming operating theaters or the triumphant newspaper headlines, but in the silent, devastating aftermath. It's a story written on the faces of the thousands who were changed forever. And to truly understand the human cost, the sheer, tragic weight of this procedure, you have to look past the statistics. You have to look at the people. And there is one story, one name, that casts a longer and darker shadow than all the others. A story kept hidden for decades, buried under the immense weight of power, ambition, and shame. The story of Rosemary Kennedy. You know the name, of course. Kennedy. It evokes images of a political dynasty, of charisma and tragedy, of a so-called American Camelot. But in the 1930s and early 40s, before the presidency and the assassinations, there was a family desperate to project an image of perfection. And Rosemary, the third child and eldest daughter, didn't quite fit the mold. She wasn't what the later stories claimed. She wasn't severely disabled from birth. She was a beautiful, sociable young woman who simply struggled. She learned to walk, to talk, to read and write, but much later than her ruthlessly competitive siblings. Her letters from the time show a sweet, somewhat naive person trying her best to keep up. But as she entered her late teens and early 20s, her difficulties became more pronounced. She was prone to mood swings, to rages and tantrums, a turbulent reflection of the immense pressure she was under. For her father, Joseph Kennedy, this was more than a family problem. It was a political liability. He was the patriarch of a clan destined for greatness. And Rosemary, with her unpredictable nature and developing sexuality, was a threat to that image. A potential scandal. A loose end that needed to be tied. In 1941, He heard about a promising new surgery, a procedure that could calm the agitated, smooth out the rough edges of a difficult personality. It was sold to him as a cure, a way to make Rosemary more manageable, more placid. The men who would perform the surgery were none other than Walter Freeman and his partner, James Watts. In November of that year, 23-year-old Rosemary was taken to a hospital. She was awake for the procedure. They told her it wouldn't hurt. They asked her to sing songs, to recite the Lord's Prayer, to tell them stories as they worked. Watts made the incisions into the front of her brain, and as he cut, Freeman would speak to her, gauging her responses. They kept cutting, deeper and deeper into the delicate frontal lobes that held the very essence of who she was. Her personality, her memories, her spark. They kept cutting until her speech became incoherent, until she fell silent. And in that silence, Rosemary Kennedy was gone. The vibrant, difficult, beautiful young woman who walked into that operating room never walked out. The lobotomy had been a catastrophic failure. It hadn't just calmed her, it had erased her. She was left with the mental capacity of a 2-year-old. She couldn't walk or speak intelligibly. She was incontinent. She would stare at walls for hours. Her father's reaction was not one of grief. It was one of cold, pragmatic damage control. He institutionalized her immediately, first in a psychiatric hospital, and then, years later, at a facility in Wisconsin. He told the world she was reclusive. He told family friends she was a teacher in the Midwest. For 20 years, her own siblings didn't know where she was or what had truly happened to her. She was simply gone. A family secret, locked away so the perfect image could remain untarnished. She would live out the next 60 years in that institution, a ghost in her own life, the first and most famous casualty of the ice pick's promise. Her story is a difficult one to hear, a stark reminder of how easily ambition can eclipse humanity. Before we explore how this hidden reality began to crack the public's perception of the lobotomy, if you are finding value in these explorations of history's darker chapters, consider subscribing to The Dark Historian. Your support helps keep these stories from being forgotten. Now, back to the silence of the forgotten patients. Rosemary's case was extreme, and it was hidden. In public, Walter Freeman was a master of promotion. He carefully curated his success stories, presenting them to a willing media. He would point to patients like a housewife who was once prone to fits of depression, now able to manage her home and children with a serene, untroubled calm. Or a war veteran, plagued by violent outbursts, now holding down a simple, repetitive job, quiet and compliant. Success, you see, was a matter of definition. Was the goal to return a person to their full, complex, and sometimes difficult self, or was the goal to make them easier for others to deal with? For the families, the asylum nurses, the society at large, the answer was often the latter. A lobotomy was a success if it produced a quiet house. It was a success if it turned a hysterical woman into an obedient, placid wife. It was a success if it made an unruly patient docile and easy to manage, reducing the number of staff needed to watch over them. This was the dark bargain. They weren't restoring a personality, they were replacing it with a void. The procedure was brutally effective at sanding away the very things that make us human: ambition, creativity, passion, spontaneity, and the capacity for deep emotional connection. the very soul of a person. And for every carefully publicized success, there were dozens, if not hundreds, of unpublicized disasters. People who, like Rosemary, were left severely disabled. But the most common outcome was something more subtle, and perhaps even more chilling. A state of profound apathy. Imagine talking to someone you've known your entire life, and they look back at you with your loved one's eyes. But there's no recognition of your shared history. No emotional response. You could tell them their house is on fire, or that they've won a fortune, and the reaction would be the same. A flat, indifferent stare. A quiet, "Oh, is that so?" This was the reality for tens of thousands. They called it surgical docility. Families reported that their loved ones had become like children, needing constant care and supervision. They had no foresight, no ability to plan for the future or learn from the past. They lived entirely in a numb, perpetual present. They lost their inhibitions, sometimes acting out in socially inappropriate ways, not from malice, but from a complete lack of the internal wiring that governs our behavior. One man, a brilliant mathematician before his lobotomy for schizophrenia, spent the rest of his life doing nothing but simple arithmetic problems over and over. A young artist, whose work was filled with passion and turmoil, could only produce childlike, simple sketches after her operation. The fire was gone. The engine of their being had been shut down. They became ghosts in their own families. A constant, living reminder of what had been lost. They were physically present, but the person who once inhabited that body was gone forever. They were a collection of basic impulses and routines, an echo of a life that had been deliberately and permanently silenced. This was the trade-off. In the quest to eliminate suffering, doctors like Freeman eliminated the sufferer. They didn't cure the patient. They erased them. And these erasures, these quiet, empty spaces in families and communities all across the country, began to add up. Each silent patient was a testament to the procedure's true nature. And though they could no longer speak for themselves, their silence was becoming a deafening roar. The murmur of doubt was growing louder, fed by thousands of personal, hidden tragedies. It was only a matter of time before someone gave that silence a voice. And so, that voice began to take shape. Not in a sudden roar of outrage, but in the quiet rustle of paper in a dimly lit office, long after the patients were asleep. It began with doctors, far from the glare of Freeman's publicity, who looked at the results of a lobotomy and felt a cold knot of dread in their stomachs. They saw the placid smiles, the unnerving docility, and they didn't see a cure. They saw a ghost. They saw a person who had been hollowed out, leaving behind a polite, manageable shell. These were the physicians who read Walter Freeman's published papers with his soaring success rates and his triumphant case studies, and then compared them to the men and women sitting in their own examination rooms. The numbers didn't add up. The stories didn't match. Freeman spoke of restored function, of housewives returning to their kitchens and men to their jobs. But these other doctors saw patients who could no longer manage their own finances, who had lost all sense of social propriety, who stared blankly at their own children, unable to summon the love that was once the core of their being. The first cracks in the facade of the ice-pick lobotomy were not ethical, but scientific. In the world of medicine, the gold standard for any new treatment is the controlled study. You take a group of patients, give half of them the new treatment, and the other half a placebo, or the existing standard of care. You compare the results blindly, rigorously, without bias. You measure, you quantify, you prove. Walter Freeman never did this, not once. His evidence was entirely anecdotal. It was a collection of stories, of hand-picked successes, of letters from grateful families who were just so relieved that their loved one was no longer violent or suicidal. He presented these anecdotes with the flair of a showman, not the sober analysis of a scientist. To a growing number of his peers, this was not just bad science. It was a dangerous deception. They began to ask uncomfortable questions in medical journals and at psychiatric conferences. Where was the data? Where were the follow-up studies that tracked patients not for 6 weeks, but for 6 years, or 16? What was the real, unvarnished relapse rate? How many of Freeman's successes ended up back in an institution, or worse? How many were living profoundly diminished lives, cared for by families who hid their disappointment behind a brave face? Freeman's response was to dismiss these critics as timid, old-fashioned, and stuck in the mud of psychoanalytic theory. He argued that the crisis in the asylums was too great to wait for the slow, ponderous pace of academic research. People were suffering now. He had a tool that could help them now. To him, a mountain of personal stories was more powerful than any sterile, double-blind study. But his critics saw something else. They saw a man who was afraid of what a real study might reveal. Then there was the fundamental question of the procedure itself. What was it actually doing? Freeman spoke in grand, confident terms about severing over emotional pathways and cutting the circuits of pathological thinking. It sounded so precise, so targeted, but the reality, as his critics knew, was anything but. Imagine trying to repair a complex circuit board with a hammer. That was the ice-pick lobotomy. The prefrontal cortex is not just a bundle of emotional wires. It is the seat of your personality. It governs judgment, foresight, empathy, creativity, ambition. It is the part of your brain that allows you to plan a future, to understand a joke, to feel regret, to weigh consequences. It is, in many ways, the very thing that makes you, you. And Freeman was plunging an ice pick into it, blindly and just, wiggling it around. Doctors who understood neuroanatomy were horrified. The damage was diffuse, unpredictable, and catastrophic. It was a neurological fragmentation bomb. You couldn't control what you were hitting. You might sever a pathway related to anxiety, but you might just as easily destroy the capacity for abstract thought or the ability to feel joy. Each patient was a gamble, and the stakes were their very soul. This wasn't just a theory. The evidence was in the patients themselves. The profound apathy, the emotional blunting. They called it the surgically induced childhood. Patients became impulsive, distractible, and unable to care for themselves. Rosemary Kennedy, after her disastrous procedure, was left with the mental capacity of a toddler, unable to speak coherently or control her own body. And while her case was hidden from the public for decades, there were thousands of other, smaller tragedies playing out in homes all across the country. It's a heavy thought to sit with. The idea of a mind being unmade by the very hands meant to heal it. Before we delve into the public's reaction to these warnings, if these historical deep dives help you find a bit of quiet in the noise, a subscription to The Dark Historian is a great way to support our work. Now, back to the medical community, where the debate was just beginning to boil over. The ethical questions were perhaps the most damning of all. The entire foundation of medicine rests on a single principle, first laid out by Hippocrates thousands of years ago. First, do no harm. How could a procedure that intentionally and permanently damaged a healthy organ be reconciled with that oath? Freeman's argument was that the brain was already sick, and that the damage he caused was a lesser evil than the suffering of mental illness. It was a trade, a terrible but necessary trade. But who had the right to make that trade on another person's behalf? Think about the patients. Many were in state asylums, declared legally incompetent. They couldn't give informed consent. The decision was made by their families, who were often desperate, exhausted, and emotionally overwhelmed. They were presented with a choice by a confident, authoritative doctor who promised a miracle. He told them this was the only hope. He didn't dwell on the risks of profound personality change, of intellectual devastation, of creating a docile, empty shell of the person they once loved. Is consent truly consent when it is given out of desperation and based on incomplete information? It's a question that haunted the medical community. In the early days, many doctors were willing to look the other way, convinced by the urgency of the asylum crisis. But as the 1940s wore on into the 1950s, that acceptance began to curdle into outrage. Voices of dissent grew louder and more prominent. In 1949, the Soviet Union officially banned the practice, with the prominent Russian psychiatrist Dr. Nikolai Gurevich denouncing it as an anti-scientific and inhumane method that turned an insane person into an idiot. The words were harsh and easily dismissed in Cold War America as communist propaganda, but the sentiment resonated with a growing number of doctors in the West. In America, psychiatrists like Dr. Leo Alexander, who had served as a medical expert at the Nuremberg trials, began to draw chilling parallels. He had seen firsthand how German doctors had justified horrific experiments on prisoners by arguing it served a greater good. He now saw his American colleagues using similar logic to justify brain mutilation. He argued passionately that lobotomy was a violation of basic human rights, an assault on the integrity of the individual. Others pointed to the disturbing social implications. They noticed that a disproportionate number of lobotomies were being performed on women, housewives who were deemed too nagging or agitated or insubordinate, women who didn't fit neatly into the prescribed domestic roles of the 1950s. The lobotomy, in these cases, looked less like a medical treatment and more like a tool of social control, a way to enforce conformity, a way to silence difficult women by literally destroying the parts of their brain that made them difficult. These criticisms weren't just whispered in hospital corridors anymore. They were being published in leading medical journals. At conferences, sessions on lobotomy became heated, contentious affairs. Doctors who had once championed the procedure began to quietly distance themselves from it. The tide of medical opinion was slowly but surely turning against Walter Freeman. He did not take it well. Freeman was not a man who tolerated dissent. He saw himself as a pioneer, a crusader, and he viewed his critics as enemies of progress. He doubled down. He traveled more, performed more lobotomies, and sought out the media with even greater fervor. He published a book called Psychosurgery with his partner James Watts, a massive tome filled with his version of events, his data, his successes. But there was a desperation to it now. He was fighting a defensive war when a study from the UK's Board of Control for Lunacy and Mental Deficiency reviewed over 10,000 lobotomy cases and found only modest results and significant, life-altering side effects. Freeman simply ignored it. He dismissed it as flawed. When his own partner, James Watts, the neurosurgeon who had performed the very first prefrontal lobotomies with him, finally broke with him over the ice pick method, Freeman saw it as a betrayal. Watts was horrified by the transorbital lobotomy, calling it crude, dangerous, and blind. He could no longer be a part of it. The partnership that had started the lobotomy revolution in America was dissolved in acrimony. Freeman was now a lone wolf. But he was a famous one. While the scientific community was abandoning him, the public still saw him as a hero. The media still loved his story. The desperate families of the mentally ill still wrote him letters, begging him to come to their town, to bring his ice pick and his medical bag, to bring his promise of peace. The stage was set for a final, dramatic confrontation. On one side was the overwhelming weight of scientific evidence and medical ethics, a chorus of sober, worried voices calling for an end to the practice. On the other side was Walter Freeman, his lobotomobile, and the power of a simple, compelling, and deeply flawed story. The cracks were no longer just visible. They were spreading through the very foundation of his life's work. The whole edifice was beginning to groan under the strain, threatening to collapse, and the world was beginning to watch. The groaning was getting louder now, not just in the press or in the hushed conversations of hospital ethics boards, but in the very foundations of psychosurgery itself. An entire medical discipline built on a foundation of shaky theory and brutal practice was beginning to feel the tremors of its own obsolescence. The world was indeed watching, waiting for the collapse. But the force that would ultimately bring the walls down didn't come from a government inquiry, a public protest, or even a rival surgeon. It came from a quiet laboratory, in a beaker of clear liquid, born from a line of research that had nothing to do with the human mind. To find the beginning of the end for the lobotomy, you have to travel to Paris in the years after the Second World War. The air there was thick with rebuilding, with a forward-looking energy. At the pharmaceutical company Rhone Poulenc, chemists were hard at work, not on mental health, but on allergies. They were developing a new class of drugs called antihistamines. You know them today as the simple pills you take for hay fever. Back then, they were cutting-edge science. A chemist named Paul Charpentier was synthesizing hundreds of variations of these compounds, tweaking their molecular structures, looking for something more effective. In 1950, he created a compound. He designated 4560RP. It was an effective antihistamine, but it had a peculiar side effect, a very peculiar one. When tested, it produced a state of profound calm. Not sleepiness exactly, something else, a kind of serene indifference. The subject was awake, aware, but seemed detached from all anxiety and agitation. The lab reports noted this strange sedative quality, but what was there to do with it? It wasn't what they were looking for. The file on 4000 560 RP might have been shelved, forgotten, another dead end in the long road of pharmaceutical research. But its story was just beginning. News of this unique compound traveled through the scientific community, and it reached the ears of a French naval surgeon named Henry Laborit. Laborit was a man haunted by what he saw in the operating theatre. He wasn't a psychiatrist. He was a surgeon trying to solve a very practical problem: surgical shock. He watched patients, even after a successful operation, wither away and die from the sheer stress their bodies endured. He believed the body's own hyper-anxious response was the killer. He was desperately searching for something to calm the system down before the scalpel ever made its first incision. When he heard about Charpentier's compound, a light went on. He obtained a sample and began giving it to his patients before surgery. The results were astounding. The patients didn't just become calm, they became disconnected. They would go into major surgery with a placid, untroubled expression. They would answer questions coherently, but they seemed entirely unbothered by the terrifying prospect of what was about to happen to them. Their bodies remained stable, their vital signs steady. The shock that had claimed so many lives simply didn't materialize. Laborit was fascinated. He saw more than just a pre-operative sedative. He saw a tool that could manage the mind's most powerful, destructive reactions. He famously described the effect as creating a disinterested state. The patient wasn't drugged into a stupor. They were simply free from their own fear. He began to use a phrase to describe what he was seeing, a phrase that was both brilliant and chilling. He called it a lobotomy pharmacologique, a pharmacological lobotomy. Think about that for a moment. All the work of Moniz and Freeman, the sterilized operating rooms, the precise measurements for drilling into the skull, the brutal, primitive force of the ice pick being hammered through the eye socket, the splintering of bone, the severing of irreplaceable tissues, the permanent, irreversible damage. All of it, the entire grotesque theater of psychosurgery, was being challenged by a simple injection, a chemical that did something similar, creating a psychic quiet, but without a single drop of blood, without a single broken bone. And here's the most important part: it was reversible. If the drug's effect was undesirable, you could simply stop administering it. The brain remained whole. The person was still there, unaltered. You could not unhammer an ice pick. You could not reconnect the severed fibers of the frontal lobes. But you could stop a drug. Laborit knew he had stumbled onto something far bigger than surgical shock. He urged his psychiatric colleagues to investigate this new compound. This, he told them, could be the key they had been looking for. This could be the answer to the overflowing asylums, the answer to the suffering that the lobotomy had tried and so often failed to address. At first, they were skeptical. Psychiatrists were used to their tools: talk therapy for the mildly ill, and the straitjacket, the padded cell, and the lobotomy for the severe. The idea that a simple chemical could quell the storms of psychosis seemed like science fiction. But two physicians at the St. Anne Hospital in Paris, Jean Delay and Pierre Denecker, were willing to try. In January of 1952, they administered the drug, now given the generic name chloropromazine, to a 24-year-old man suffering from a severe manic episode. For weeks, this man had been a whirlwind of frantic energy. He was agitated, aggressive, incoherent, and had not slept for days, he was a classic candidate for a lobotomy. He was exactly the kind of patient that Freeman would have seen as a perfect subject for the transorbital procedure. Instead, he was given an injection. The effect was not immediate, but over the next few hours, a quiet fell over him. A quiet that no one in the hospital had ever seen induced so gently. His mania subsided, his aggression dissolved. Within a day, he was calm. Within 3 weeks of continued treatment, his symptoms had vanished. He was lucid, rational, and able to carry on a normal conversation. He was, for all intents and purposes, back. The person who had been lost in the storm of his own mind had returned. DeLay and Denneker knew they were witnessing a revolution. They immediately began treating more patients, dozens of them, suffering from schizophrenia, mania, and other psychotic disorders. The results were consistent. The drug didn't cure them, not in the way an antibiotic cures an infection, but it managed the symptoms. It quieted the auditory hallucinations, the terrifying voices that so many patients heard. It calmed the frantic, paranoid thoughts. It made patients accessible again. It allowed them to engage in therapy, to connect with others, to simply exist without the constant torment of their illness. This single pill, this one chemical compound, was about to dismantle an entire medical empire built on steel and force. Before we see how that empire crumbled, if you find these explorations into the shadows of history compelling, a simple subscription to the Dark Historian helps us continue to bring them to light. We appreciate your support. Now, back to the revolution in a bottle. News of the Paris cure spread like wildfire through the global psychiatric community. In the United States, the pharmaceutical company Smith, Kline and French licensed the drug and prepared to bring it to the American market. They gave it a powerful, memorable brand name, one that sounded like something out of Norse mythology: Thorazine. The first American trials began in 1954, and the results mirrored what DeLay and Denneker had seen in Paris. At state hospitals across the country, doctors who had been presiding over wards filled with screaming, agitated, and violent patients suddenly found they could achieve a level of calm they had never dreamed possible. Wards that had been chaotic war zones became quiet, manageable spaces. Patients who had been locked in isolation for years could now sit calmly in a day room. The effect on the practice of lobotomy was immediate and catastrophic. Why would any doctor, any family, any patient choose the ice pick when the pill was an option? Think of the choice. On one hand, you have an invasive, dangerous, and permanent brain surgery with a high risk of turning the patient into an emotional zombie or worse. On the other, you have a medication, a simple tablet. It was non-invasive, it was adjustable, and most critically, it was reversible. Suddenly, Walter Freeman's arguments began to look not just old-fashioned, but barbaric. His crusade to sever the brain's connections was rendered obsolete overnight by a chemist who was just trying to cure a runny nose. The number of lobotomies performed in the United States plummeted. In 1949, at the height of the craze, over 5,000 lobotomies were performed. By the mid-1950s, with Thorazine widely available, the number had fallen by more than half. By the early 1960s, it was in the low hundreds. The procedure was dying. Thorazine was not a miracle drug, not by any means. It came with its own host of serious side effects. Patients often developed a telltale sluggishness, a blunting of emotion, and a slow, shuffling walk that became known grimly as the Thorazine shuffle. It could cause severe motor problems, tremors, and a condition called tardive dyskinesia, characterized by involuntary, repetitive body movements. It was, in its own way, a chemical straitjacket. It controlled patients, made them more manageable, but it didn't necessarily make them well. But here is the crucial difference. It was a straitjacket that could be loosened, or even removed. The ice pick offered no such recourse. The choice for doctors and families was no longer between a chaotic mind and a surgically muted one. Now there was a third option, a chemical option. The arrival of Thorazine exposed the lobotomy for what it truly was, a crude, desperate, and brutal tool from a pre-scientific era. It was the medical equivalent of using a sledgehammer to fix a watch. Now, psychiatrists had a finer instrument. It was still imperfect, still clumsy in many ways, but it was an instrument of chemistry, not of force. The great, hulking institutions of psychosurgery, the gleaming operating theaters, the custom-made leucotomes and orbitoclasts, the entire mythology built up by men like Freeman, all of it was made to look like a relic from a darker age. The hero surgeon, striding into the asylum to bring peace with a sharp instrument, was being replaced by a new figure, the pharmacist, quietly dispensing order in a small, white pill. The ice pick had been put back in the drawer, but the quiet hum of the asylums was about to be replaced by a different kind of silence altogether. That new silence was not one of emptiness. It was the sound of a revolution arriving on tiptoe. It began in France in the mid-1950s, not with a scalpel or an ice pick, but with a simple chemical compound, chloropromazine. In America, it would be given a name that sounded like a promise: Thorazine. It was developed as an anesthetic, something to calm patients before surgery. But doctors noticed something strange. It did more than relax the body. It quieted the mind. It didn't cure schizophrenia. It didn't erase depression. But it could tether a person to reality. It could quell the terrifying hallucinations, the frantic, paranoid thoughts. It could smooth the violent peaks and valleys of psychosis into gentle, manageable hills. For the first time, there was a tool that could manage severe mental illness without destroying the brain. The effect was profound, and it was fast. Ward after ward, the endless screaming and crying began to subside. The padded cells saw less use. The restraints gathered dust. The new sound of the asylum was the gentle rattle of a pill in a paper cup, the quiet murmur of a conversation where once there had been only incoherent rage. This was a different kind of peace. It was not the blank, placid emptiness of the lobotomized patient. It was a functional calm, a chemical negotiation, and for the medical establishment, it was a miracle. It was cheaper than surgery. It was reversible. It was far, far less terrifying to the public. The tide turned against the lobotomy with a speed that was breathtaking. The very doctors who had championed it just a few years earlier now spoke of it in hushed, embarrassed tones. It was suddenly seen for what it was, a relic, a brutal, desperate measure from a darker, more ignorant time. And what of the great crusader, Walter Freeman? How does a man react when his life's work, his great gift to humanity, is rendered obsolete overnight by a little yellow pill? He did not react with grace. He reacted with fury. He saw thorazine not as a breakthrough, but as a crutch, a chemical lobotomy. He called it, sneering at its effects. He argued that the drugs merely masked the symptoms, trapping the patient in a chemical prison, while his procedure offered a true, permanent liberation. He believed his method was an elegant, anatomical solution, while these new drugs were a clumsy, shotgun approach, flooding the entire system with chemicals. You can almost picture him, can't you? A man standing on a shore, watching his entire world get washed away by a tide he cannot control, and instead of moving to higher ground, he simply shouts at the ocean. He traveled the country, giving lectures, showing his slides, trying to convince his colleagues that they were making a terrible mistake. But the rooms were emptier now. The applause was muted. The invitations from prestigious hospitals stopped coming. His partner, James Watts, had long since abandoned him, horrified by the transorbital procedure and the assembly line fashion in which Freeman performed it. Watts went back to careful, precise, traditional neurosurgery, his name forever linked to a procedure he had come to regret. But Freeman could not stop. To stop would be to admit that the last 20 years of his life, the thousands of brains he had altered, the entire philosophy he had built had all been for nothing. Or worse, that it had been a colossal, tragic error. And so he doubled down. He became a traveling salesman for a product no one wanted to buy. His lobotomobile became a more permanent fixture on the backroads of America. He no longer went to the great state hospitals of New York or Pennsylvania. He went to the small, underfunded, forgotten asylums in West Virginia, in Texas, in rural California, places where the new drugs were too expensive or too slow to arrive, places where desperation was still a currency he could spend. He was a ghost haunting the hallways of modern psychiatry. His colleagues would warn their students about him. The ice pick man, a cautionary tale, a symbol of surgical hubris. But to the families still trapped in the nightmare of a loved one's illness, to the overworked staff of a forgotten institution, he still looked like a savior. He still offered a solution, a final, definitive answer. Before we follow Freeman on this last, lonely journey, if you find this exploration of history helps you find a quiet space to rest, a small gesture like subscribing to The Dark Historian helps support the creation of more stories like this one, it is deeply appreciated. Now back to the fading light of a once-celebrated career. His practice dwindled from hundreds of lobotomies a year to a few dozen. Then to just a handful. He was in his 60s now, but his energy seemed undiminished, fueled by a deep, unshakable conviction. He kept meticulous records of every single patient, writing to them for years, for decades, trying to gather evidence that his work had been a success. He would cherry-pick the positive outcomes, the thank-you letters from grateful families, and hold them up as proof. The failures, the relapses, the empty shells he left behind, those were easier to ignore. He was chasing his own legacy, trying to write the final chapter himself. But history had other plans. The final chapter would be written for him in a small private hospital in Berkeley, California, on a cold day in February of 1967. The patient was a woman named Helen Mortensen. She was not a stranger to Freeman's work. In fact, he had lobotomized her twice before. She suffered from severe agitated depression, and after her last procedure over a decade earlier, she had found some measure of peace. She had been functional, even happy, for a time. But in the mid-1960s, her symptoms had returned with a vengeance. Her family, remembering the relief the surgery had once brought, sought out the only man they knew who could help. They found Walter Freeman. He was 71 years old now. His hands, perhaps, were not as steady as they once were, but his confidence was absolute. He saw Helen's relapse, not as a failure of the procedure, but as evidence that it simply hadn't gone far enough. The connections had regrown, he reasoned. He just needed to sever them again, more thoroughly this time. It would be his third transorbital lobotomy on the same person. The procedure was the same one he had performed thousands of times. The insertion of the orbitoclast above the eyeball, the tap of the mallet, the sweeping motion to sever the frontal lobe fibers. But this time, something went wrong, deep within Helen Mortensen's brain. As the steel instrument moved, it tore something it should not have. A blood vessel, a cerebral artery. The hemorrhage would have been catastrophic and immediate. A sudden, unstoppable bleed in the most delicate and vital part of the human body. There was nothing he could do. There was nothing anyone could do. Helen Mortensen died there on the table, the last patient of the ice-pick lobotomy. This was not a death that could be ignored. It wasn't a quiet descent into apathy in a back ward years later. It was a direct, undeniable result of the procedure itself. An investigation was launched. The medical community, which had been trying to quietly distance itself from Freeman for years, now had its moment. They could finally close the door on this chapter of their history. Walter Freeman's surgical privileges were revoked. For good. It wasn't a dramatic trial. There were no grand speeches. It was a quiet, bureaucratic decision. The man who had personally severed the frontal lobes of nearly 3,500 people was told, simply, that he was no longer allowed to practice medicine. The great crusade was over. The lobotomobile was parked for the last time. He spent the final few years of his life in a kind of self-imposed exile. He didn't hide in shame. Instead, he took to the road one last time, not with his ice pick, but with a camera. He drove across the country, visiting his former patients, the ones who were still alive and who would still see him. He took their pictures. He interviewed them. He was still trying to prove he had been right. He was compiling the data, organizing the photos, preparing the definitive defense of his life's work. He died of cancer in 1972, his great book unfinished, his reputation in ruins. He died believing he was a pioneer, a misunderstood genius who had brought light into the darkness. Most of the world would remember him as something else entirely. A monster, a madman, a butcher. The truth, as it so often is, rests somewhere in the vast, grey space in between. He was a man of his time, armed with crude tools and a desperate desire to fix what seemed irrevocably broken. He offered a terrible solution to an even more terrible problem. And when the world moved on, when better, gentler solutions were found, he was either unable or unwilling to move with it. He pursued his cure with a zealot's conviction, right up to the very end. He chased a silence in the minds of others, a quiet he believed was peace. But in the end, the only silence that mattered was the one that fell after his last patient's final breath, and the quiet closing of a door on one of the darkest, strangest, and most troubling chapters in the history of medicine. The era of the ice pick was finally and completely over. And so, the door closed. A simple, quiet sound that ended an age of noise. The noise of the whirring drill, the sharp tap of the hammer, the desperate cries, and the even more desperate hopes that filled the halls of 1,000 forgotten hospitals. In the silence that followed, a new sound began to emerge. Not a sound of instruments or of shouting, but the quiet, persistent rustle of turning pages, of dusty files being opened, of a generation of doctors and ethicists looking back into the darkness and asking a single, soul-shattering question. What have we done? The end of the ice pick lobotomy was not a sudden event. It was a slow, creeping dawn. It was the arrival of thorazine and other antipsychotic medications in the mid-1950s, drugs that could quell psychosis and manage symptoms without destroying the brain. They were not a perfect solution, far from it, but they were a key in a lock that, for decades, had only been met with a hammer. They offered a chemical alternative to a surgical one, and for the first time, the medical establishment had a real choice, a way to treat the mind without violating the brain. The story of the lobotomy became a ghost story told in medical schools, a cautionary tale of hubris, a chilling example of what happens when a cure becomes more terrifying than the disease. The very name, once a beacon of scientific progress, became a slur, a shorthand for medical barbarism. The thousands upon thousands of patients, the ones who had been cured by Walter Freeman and his disciples, were largely forgotten by the public. They became inconvenient truths, living reminders of a collective failure. They were the quiet ones at family gatherings, the people with the faraway look in their eyes, their inner worlds scraped clean, their passions and their pains reduced to a manageable, placid grey. Their stories, when they could be told, were not of miraculous recovery. They were stories of loss, the loss of memory, of ambition, of the spark that makes a person who they are. A wife who no longer recognized the music she once loved to dance to. A soldier who survived a war only to lose himself in a quiet, sterile room. A brilliant young woman, a Kennedy no less, reduced to the cognitive state of a toddler, her life a ghost of what it could have been. This was the true legacy of the lobotomy, not the Nobel Prize, not the newspaper headlines. It was the silent, echoing void left in the lives of tens of thousands of people and the families who had to live with the consequences. They had been promised a miracle, a release from the prison of mental illness. What many of them received was a different kind of prison. A quieter one, perhaps, but a prison all the same. A cage of apathy, where the bars were made not of steel, but of severed neural pathways. From these ashes, however, something essential was born. The modern concept of informed consent. Think about it. Before this era, the doctor was often seen as an unquestionable authority, a paternalistic figure who knew best. You went to them, you told them your problem, and you did what you were told. The idea that a patient, especially a mentally ill patient, had the right to fully understand the risks and benefits of a procedure and to refuse it was revolutionary. The horrors of the lobotomy, laid bare for all to see, forced a fundamental shift in that relationship. It created a new and sacred trust, built on the principle that the person who inhabits the body is the ultimate authority over it. No more would a doctor be able to travel the country in a van, performing irreversible brain surgery in hotel rooms with the casual confidence of a shoe salesman. The era of the medical messiah was over. The era of the patient as a partner had begun. It was a lesson written in scars, both visible and invisible, a promise to never again sacrifice the person to save the patient. And it leads us to wonder, as we look back from our modern vantage point, how could this have ever happened? How could so many brilliant minds, so many well-intentioned healers, have embraced such a brutal and imprecise practice? The answer is as complex and unsettling as the brain itself. It was a perfect storm of desperation, ambition, and ignorance. The desperation was real. The state asylums of the early 20th century were places of unimaginable suffering. Overcrowded, underfunded, and with few effective treatments. They were warehouses for the forgotten, for the families and doctors facing the agony of severe, untreatable mental illness. Any hope, no matter how slim or how drastic, was a light in the darkness. They were not evil people. They were people at the end of their rope. The ambition was personified by men like Walter Freeman, a showman, a crusader, a man so convinced of his own righteousness that he became blind to the devastation he was causing. He saw himself as a liberator, freeing people from their troubled minds. He believed in his mission with an almost religious fervor, and that certainty is a powerful and dangerous force. He wasn't just performing a surgery. He was waging a war, and in war, there are always casualties. And then there was the ignorance, the simple, profound fact that they just didn't understand. They saw the brain as a machine, a collection of wires that could be cut and rerouted to fix a problem. They lacked the tools to see the symphony, the intricate, delicate dance of chemistry and electricity that creates a thought, a memory, a feeling. They were like mechanics trying to fix a supercomputer with a hammer and a screwdriver, smashing vital components in a blind attempt to stop a glitch in the software. Today, our view of the brain is vastly different. We haven't solved its mysteries, not even close, but we approach it with a reverence and a caution born from the mistakes of the past. When neurosurgery is performed today for psychiatric conditions, it is nothing like the lobotomy. It is a world away from the ice pick and the orbitoclast. It is used only in the most extreme, treatment-resistant cases, perhaps for severe obsessive-compulsive disorder that has resisted every other therapy, or for intractable epilepsy that threatens the patient's life. And the procedure itself is a marvel of modern science. It is not a blind swing in the dark. It is a feat of microscopic precision. Imagine a surgeon guided by incredibly detailed MRI scans mapping the brain in 3 dimensions. They are not severing vast tracts of tissue. Instead, they might use a focused beam of radiation, a gamma knife, to target a tiny millimeter-sized cluster of malfunctioning neurons. Or they might implant a delicate electrode for deep brain stimulation, a device that acts like a pacemaker for the brain, sending tiny electrical impulses to regulate a faulty circuit. The goal is not to quiet the brain, but to restore its harmony, not to erase a personality, but to free it from the grip of a debilitating illness. And every step of the way, the patient is a partner. There are extensive ethical reviews, psychological evaluations, and long, detailed conversations about risks and potential outcomes. The choice belongs to the patient, and to them alone. The ghost of Walter Freeman stands in the corner of every one of those rooms, a silent reminder of the profound responsibility that comes with wielding the power to alter a human mind. So, is the story of the lobotomy simply a grim relic of a bygone era, a dark chapter we can close and put on the shelf, confident that we know better now? Perhaps. But its lessons are not locked in the past. They are timeless. The story of the lobotomy is a story about the danger of simple answers to complex problems. It's a warning against the seductive allure of the quick fix. Mental illness is not a faulty wire to be cut. It is a deeply complex interplay of biology, environment, and experience, and treating it requires patience, compassion, and a deep, abiding humility. It's a reminder that scientific progress without ethical oversight is a runaway train. Our ability to do something does not automatically give us the right to do it. The most important question a scientist or a doctor can ask is not can we, but should we? And the answer to that question must always be guided by a profound respect for human dignity. And finally, it's a story about us, about our fear of the unknown, especially the unknown within our own minds. The lobotomy was born, in part, from a desire to control the uncontrollable, to silence the parts of human nature that are messy, unpredictable, and frightening. It was an attempt to enforce normalcy with a blade. But the human spirit, the thing that makes us who we are, is not meant to be simple or silent. It is a chorus of joys and sorrows, of brilliance and madness, of light and of shadow. To extinguish one is to diminish the other. As you lie there now, in the quiet of the room, feel the gentle, rhythmic hum of your own mind. A universe of thought, of memory, of dreams, all contained within the fragile vessel of your skull. It is the most complex and beautiful object in the known universe. For decades, we tried to understand it by breaking it. We've learned, through bitter experience, that the only way to truly understand it is to listen with better tools, with greater empathy, and with the quiet awe it deserves. The ice pick is gone. It rests now in a museum, a cold, sterile artifact. But the questions it raised are still with us. How do we care for the most vulnerable among us? How do we balance the desire to heal with the duty to do no harm? And how do we navigate the vast, uncharted territory of the human mind without losing our own humanity in the process? There are no easy answers. The journey continues. The quiet work of understanding goes on, day by day, in laboratories and hospitals around the world. We are still just scratching the surface, still standing on the shore of a vast and mysterious ocean. And perhaps the greatest lesson from this dark history is the knowledge that when we approach that ocean, we must do so not with the arrogance of a conqueror, but with the gentle, patient hand of a cartographer, mapping a world of infinite wonder, one precious life at a time.